I'd like to talk to you today about long-term conditions. I guess that each and every one of you watching this can bring into your mind's eye now somebody who you know, who has a long-term condition, who you care for, who you are a professional for. And you can visualize them. If you multiply that person by 252%, that is where we are in this country by 2040. That the rise in the number of people who not just have a single long-term condition but multiple will be exponential. A tsunami of need, which if we continue to manage the health and social care system as we do now, it will not be sustainable. At this moment, 70% of the activity and cost of your organisation, your health economy, is based upon the use of those health and social care services by people with long-term conditions. And some 70% of unscheduled admissions are down to those same people. But it isn't just one condition. Those of us who work in primary care know that the people who we see across our desks have multiple conditions. Some data just recently from Scotland, the University of Glasgow, showed very comprehensively, looking at 1.3 million patients, 1.3 million, that of those over 65, the majority had 2 or more conditions. Those over 75, the majority had 3 or more conditions. That if you take people with diabetes, only 14% of those people have just diabetes. If you take COPD, only 18% of those people have just COPD. That is why I say that we need to get away from the position where there is almost a Monty Python-esque queue of case managers outside a single person's house because they just have one disease hat on, but the person inside has 3 or 4. To a position where we recognise that comorbidity is the norm, that thinking just down disease-specific pathways is a redundant strategy for the future that faces us. That the inexorable rise that has happened in the last 10 years of some 30-odd%, 36% in unscheduled admissions isn't one that we can continue to see happen. Not least because it's actually poor care for our patients ultimately, moving in and out of hospital, having the fragmentation of their days, not seeing a fully comprehensive, coordinated effort. Because if we look at the literature and we look around the world, we know how we can do this better. That if we take the examples of Jönköping in Sweden and the Netherlands and Alaska and Tayside in Scotland and increasingly places here, we see there is a system of care that you can put in place which changes that. A system that in Sweden, for example, over that same 10-year period, saw a rise of only 1.6% in unscheduled admissions, that in places in Liverpool now has seen a sharp decline in unscheduled admissions against a rising background in the rest of the country. And these are the components of that system. First, risk stratifying the population with long-term conditions. Out of that drops a list of names. That list of names some people call a virtual ward, but it's a list of names. Determining how far down that risk profile you go and having that group of patients looked at a local level by an integrated care team, health, social care, community services, primary care, seeing who amongst them is the best person to relate to an individual. It might be the COPD specialist nurse, it might be the diabetic specialist nurse, but looking at that patient as a whole. And having done that, being proactive in their management. Seeking to shape what happens to keep them at home to maximise their functionality. And the third is having a systematic approach to helping people to co-manage or self-care their condition with shared decision making and care planning. And that's not just a soft and nice thing to do, but there's really robust evidence that it improves the clinical outcomes, as well as improving the experience of patients, and also making more effective use of the resources that are available to all of us. And you know, if you look at what patients say in focus groups or in surveys, they say very, very clearly, I want you to deal with the whole of me, and I want you to act as one team. Now, on the long-term conditions workstream, that's precisely what we're trying to do with colleagues all around the country, to seek to implement this system, because the King's Fund and others are really clear that the evidence says you need to put them all in place comprehensively across a health economy. Get away from the disease that the NHS has suffered from years, what I call chronic pilotitis, re-evaluating what's already been evaluated. We don't have the time or the resource to do that. We need to learn from elsewhere. The focus now is on implementation. That is why these three drivers, risk stratification, integrated neighbourhood care teams, systematising self-care, are part of the operating framework for the NHS. That is why David Nicholson has said that for the National Commissioning Board, long-term condition management will be the priority for the National Commissioning Board. And that is why we are seeking to help you implement in your geography, for your patients, your citizens, this system of care. How you do it, how you tailor it, entirely, of course, up to yourselves. And we now have some clinical commissioning groups across the country whose population totals 20 million or so engaged in this work. And we're sharing information across the country as well as within your regions to help everybody do this faster and more effectively. And we suggest that when you do this implementation, you track what you're doing. And based upon the experience of others, there are milestones which we would commend to you. So, for example, in risk stratification, have you chosen a tool? Can you use it? Is the technicalities and the logistics sorted? Having got it working and implemented in practices that cover at least 50% of your population in a way that means that that data is systematically looked at and acted upon. And then finally, making sure that that risk stratification data is systematically looked at by an integrated care team for the totality of your population. Those are the milestones. And similarly, for integrated care teams and for systematising the mechanism of self-care. That's why I hope that you will now become a member of this family that is developing to change and improve the way that we manage people with long-term conditions in this country. And some of you may have heard me say this before, but I don't apologise for saying it again. That if we fail, we're not failing the government, we're not failing the NHS, we're not failing the CCG, we're failing those people you brought into your mind's eye, we're failing your friends, your relatives, your communities. Thank you for listening. May the force be with you.